A very warm welcome, everyone. I, Dr. Ritika Dhiman, on behalf of Voice of Healthcare, welcomes the speakers and the viewers who have joined in for today's one on one discussion on closing the screening gap, organized by Voice of Healthcare and supported by Medora Meditech to recognize Colorectal Cancer Awareness Month. To commence this session, I would like to introduce our speakers. I welcome Dr. Randhir Sood, Chairman, Institute of Digestive and Hepatobiliary Sciences, Medanta, Gurugram. Welcome, Dr. Sood.
Hello.
I, wel- I welcome Dr. Amanjeet Singh, Director and Head, Colorectal Surgery Division of GI Surgery, GI Oncology, Minimal Access and Bariatric Surgery, Medanta, Gurugram. Welcome, Dr. Singh.
Thank you, Ji.
So I hand over the session to both of you, sir, now.
Okay. So good morning, everyone. So first of all, thanks, Dr. Sood, for joining us. I hope we'll be able to give some messages to the audience. So we'll be talking about colorectal cancers, how to prevent them, what is the treatment options available, and what are the options if somebody develops cancer. So first of all, Dr. Sood, thanks for joining us today. So for the benefit of viewers, first of all, I would like to know that what is the incidence of colorectal cancer? Is it that really important? And among other body cancers, how prevalent is it?
Dr. Aman, thank you for asking. Yeah, thanks for asking this question because this is very important and pertinent, for people to know that how frequent is colorectal cancer in India, because it's a myth that colorectal cancer is very infrequent in India, so we don't have to be really worried about it. You see, in 2020, there are figures of 2020 with me, and in males, colorectal cancer is fourth commonest cancer after prostate, after lung, and oral cavity. The fourth common cancer is the colorectal cancer. In females, it is the fifth common cancer after uterine cancer, breast cancer, uterine cancer, ovarian cancer, and oral cavity cancer, and then colorectal cancer. 6.3% of incidence is in males, and around 4.8% is in females. So it's not infrequent; it's fairly common, and it is expected that by 2040 we'll be actually almost doubling the incidence of colorectal cancer, coming very close to where the West is today.
Okay. As I think there is a myth among common public that it's maybe a white man's disease or it's an old man disease. So is it really true, or do you see this colorectal cancer in younger population also?
In fact, in India, we see colorectal cancer in much younger patients, and in more advanced stage, because we are not doing anything to prevent it or to diagnose it very early, and the people also come to us late. And in fact, we see this happening a decade earlier. In West, the colorectal cancer, only 20% of colorectal cancers happen in people below the age of 45, and rest happen after that. In India, we do not have that kind of age-related figures, but my assumption is that if we really get the data, it will show us that we are getting younger people getting affected by colorectal cancer.
Yes, I think, and it's actually an observation that probably these younger patients, they have a poor prognosis compared to the elderly one. So what's your thought on that?
Yeah, that's right. In fact, that only tells us that maybe our strategy to catch this cancer before it happens has to be very robust and has to start at the right time so that we can prevent, this from getting into advanced stage and even prevent people from getting colorectal cancer.
So that means actually we should be worried about the increasing incidence of colorectal cancer in India also. So just for the benefit of the audience, what are the common symptoms? So when should someone think that no, I need to have screen or I should see a consult a doctor?
You see, there's some certain symptoms which will point towards colorectal cancer. These will be, somebody suddenly starts having a change in his bowel habits. That person was going to the stools normally, and now is having more frequent stools, or is constipated, or has, is having a very different caliber of stools. One should be getting cautious about it, particularly if it has happened, never happened in life, and now suddenly it started. Second, if there is blood in the stool which is consistent. And third, if a person is having loss of appetite, feeling weak, and is having loss of sorry, I think we got
I think there
disconnected.
was some connectivity issue. Yes, sir. So I think you had
Okay,
enumerated two symptoms: so bleeding and any unexplained weight loss, change in bowel habit. So anything else,
that's
sir?
right. Patient coming with iron deficiency anemia. That person, when gets a blood test done, finds that his hemoglobin is low, or a female who is postmenopausal and finds the hemoglobin to be low. This needs to be investigated seriously, should not be taken lightly, because we see patients coming that, okay, my hemoglobin was found to be low, then my doctor gave me iron, and or I started taking iron, and this has been going on for last 6 months or a year, and then we find that the person is coming to us with advanced cancer. So if you are a male and you are having iron deficiency anemia, go to your doctor, get yourself investigated, because this could be one of the symptoms of signs of colorectal cancer. And if you're a lady not having excessive menstruation, or you're postmenopausal and having iron deficiency anemia, it is very important that you should consult a doctor, or if you're having bleeding in the stools.
Yes, so as very rightly said by Dr. Sood, any unexplained weight loss, unexplained anemia, so change in bowel habits, so all these symptoms, they we call them as a red flag sign. So if any one of you is having these kind of symptom, it's always better to consult a doctor and let him decide whether you need screening or not. So any risk factor, or the all population, they are at the same level or at risk for colorectal cancer, or are there any specific group where you think that they're at a higher risk and maybe they need screening earlier?
Yes, again, thank you, Dr. Aman, for asking this question, because this is very important. That this is the burning, thought in with the people around, that am I at risk, and what makes me at higher risk than normal population. You see, if you have a family history of your first degree blood relation having cancer, colon cancer, then you are at a almost at 3 times the risk of a normal population. But if you have more than two, or more than two relatives, first degree relatives who have colon cancer, your risk even is much higher. Similarly, if you have a second degree relative, some cousins, and then again you are at a high risk of colorectal cancer. Particularly if any of your relations got the cancer below the age of 45 years, then this risk becomes even higher, and we need to be proactive in finding the screening people who are relatives of these patients, to find whether they are harboring any harbingers of colon cancer, like polyps and all. Similarly, people with ulcerative colitis or Crohn's disease, inflammatory bowel disease as we call it, they're at a high risk of getting colon cancer. People with obesity, people who are taking too much of processed red meat, people who are smokers, they are people who are at a high risk of developing colorectal cancer. So I think we should screen them. Then there are certain genetic disorders where people have a very high risk of colorectal cancer. Almost nearly 70-80% of them will develop it. These are patients with familial adenomatous polyposis or polyposis syndromes. They must get screening, and they must get appropriate treatment in time to prevent them from getting colon cancer. Then patients who have got what we where there is colon cancer in a younger relative, who may be having, we call it hereditary non-polyp colon cancer syndrome, and these patients also the relatives of these patients also at a high risk and should get screened.
Yes. So basically, if you are a high risk group, which he has enumerated, or you have these red flag signs, so probably you are a candidate for screening. So, Dr. Sood, again, just for the audience, what are the various screening options available with us? So, how to do a
Well,
screening for colorectal cancers?
you have, yeah, you have two sets of screening procedures. One is stool-based screening, that you give a stool sample and we check presence of occult blood. Occult blood is not visible, but you check it for occult blood by certain chemical testing. Either it is immunochemical testing or it is through a conventional GWAC test. We check it. We call it occult blood in the stool, and if it is positive, if these patients need to be screened with a sigmoidoscopy or a colonoscopy. Sigmoidoscopy is the endoscopy through the rectum of a limited area of the large intestine up to 40 centimeters, while a colonoscopy is seeing the entire large intestine to see if the patient has polyps or colorectal cancer. Because if you do this in patients who have got stool test positive, you can bring down the incidence of colorectal cancer by almost 30%. The second screening option is through directly going to the colonoscopy and doing at a particularly people who are at a high risk and people who are on periodic screening. They should have a colonic screening at after the age of 45. Now in West we don't have that benchmark set in India yet, but I think we should follow the same and start screening people above the age of 45, and particularly if they're high risk. And we should do the second screening first time after 5 years, and then 10 years later if there's no polyps or no cancer found, to prevent them from getting any colorectal cancer throughout their life.
Okay. So, Dr. Sood, you mentioned about the polyps. So, can you just elaborate what are polyps and are they the precursors for malignancy?
Yeah. So polyps are like seeds of cancer. Good thing about colorectal cancer is that it grows over 5 to 10 years in a patient, and in fact longer. Patient first will develop some polyps. These are polyps are small, tiny growths like nodules in the colon, which can be detected through the colonoscopy. And today's colonoscopes, which are high magnification and have got virtual chromoscopy, can detect these polyps very early, and when we detect them, we remove them. And these are called polyps. They can be, when you start screening people in the Western data, 50% of people will have some polyps, but only 10% of these polyps have the potential to grow into cancers. So, but there is a way to know which are the polyps which are at high risk of growing into cancer. If we find those polyps, we remove them. And then we shorten the interval of screening in these people to make sure that they do not get further polyps, or we are able to remove them, these polyps, before they grow into a full-blown cancer.
Yes, as very rightly said by Dr. Sood. So we have that window of opportunity, and that is why
Yeah.
we actually focus on the screening for colorectal cancer. That if you can find the cancer at an early stage, you can actually cure it. So after these things, so if a patient gets a colorectal cancer, suppose he is diagnosed with a colorectal cancer. So what are the various options available to the patient in terms of treatment?
Well, majority of the colorectal cancers, when we detect, we also detect what is the extent of their involvement, that what is their spread. Are they limited to the colon? Are they, if they are limited to the colon, are they limited to the only the internal wall of the colon, or they have got lymph nodes, or they have already penetrated the colonic wall? Then in large majority of patients, the treatment remains surgery. And whether they will need anything beyond surgery will depend upon what the surgical specimen biopsy show. If that colorectal cancer has gone beyond the wall, or has lymph nodes, or has deposits elsewhere in the body, then this patient will be a candidate for chemotherapy after surgery. And similarly, if we have rectal cancer that is in the lower 15 centimeters of the colon, then these patients, if they have even infiltration to the wall, they, Dr. Aman is, who is interviewing me, is actually a surgeon who is the chief of colorectal surgery in Medanta. So then he will prefer that these patients are given radiation before he goes for surgery, so that he can remove the entire cancer in one go. So so that is called neoadjuvant treatment of this rectal cancer before we do it. But ultimately, it is surgical intervention, except very few cases who are not surgically fit, or where there is the cancer is limited to the internal wall, that is the mucosa of the colon. There we can do endoscopic resection. We call it EMR or ESD, and this we use very judiciously in people where we think the cancer is only limited to the internal wall of the colon, and it's not meant for anybody who has more advanced cancer or who is surgical candidate.
Yes. So, being a surgeon, I would also like to add that actually surgery is not that morbid as it was earlier thought. So now we can do the surgery through small holes, which we call as laparoscopically, or even by robots. So the morbidity of surgery by third, fourth day, patient can actually resume their normal activities. So after the surgery, Dr. Sud, would you like to add how to follow up these patients so that there is
Well,
because every cancer has a chance of recurrence.
so first is after the patient recovers and after we have decided whether the patient is going to surgery is going to the final stop for the patient, or whether the patient needs any additional chemotherapy or radiation. That is, once that is patient is over the treatment, we need to do what we call surveillance to see whether there is any recurrence. And normally, whatever recurrences happen within first 3 to 5 years. So 5-year benchmark is kept for colorectal cancer, rather in most of the cancer, as the point where we declare whether the patient is free of cancer from which he or she suffered earlier. So what we do is we periodically get their blood test done, and which also includes certain tumor markers, particularly if that tumor markers is high before surgery. And second, if we do their CT scans to see whether there is any recurrence of any lymph nodes or tumor outside the colon. And third, we do a colonoscopy, which we do after first surgery. We do it after a year, and then at 3 years, and then after at the end of 5 years, to certain that there is no recurrence inside the colon.
So one common myth, Dr. Sood, again in general public is that once you are diagnosed with cancer, the outcome is not good. Is that true for colorectal cancer also, or the outcome is somewhat different?
See, two cancers, breast and colorectal, are cancers which I feel and I term them as curable cancers, which horrifies you when you're diagnosed, but these are curable and you will have lead normal life, unless you are unfortunate and you got diagnosed very late in the course of the disease. So we should consider colorectal cancer as a curable disease, giving you normal lifespan and normal quality of life after surgery. But the onus is on you to get it diagnosed either before colorectal cancer develops, or come to the doctor early so that it is detected early.
Okay. So if you see the tagline of Dr. Sood, the American Cancer Society, they say it's a preventable, beatable, treatable. So is it really
Yes.
preventable? So are there any changes in our diet or lifestyle which we can make people aware to decrease the incidence also?
Yes, I think prevention of colorectal cancer lifestyle modifications are three. One, high fiber diet, taking dairy related products up to 400 grams has been shown to decrease the incidence of colorectal cancer. Third is exercise. These three interventions are linked with a decrease in incidence of colorectal cancer. That high fiber diet, this is pattewar, leafy green vegetables and fruits being predominant part of your diet, avoiding processed red meats, and so this is one. Second, prevention, which is prevention is getting yourself screened without symptoms in time, particularly if you are high risk.
Okay. So I think Dr. Sood has very nicely covered all the topics. So would you like, being a, I think, pioneer in endoscopy, what are the other endoscopic options like stents or something which are available for the treatment of colorectal cancer, sir?
See,
For
endoscopy,
incurable cancer, advanced cancer.
once the cancer is very advanced, and it is causing obstruction to the intestines, and patients come with sudden obstruction to the intestines, it becomes a difficult choice for the surgeon to give a person a curative surgery. At that time, we can go in with the endoscope, put in stent. Stent is just like a scaffolding which opens up the passage of the colon so that the stools can pass, and gives us time for better planning of the curative treatment for the colorectal cancer. So it is palliative treatment for obstruction. But in patients who are very advanced, where surgery is impossible and cancer is causing obstruction to the large intestine, again we have this kind of stenting which we do to give them palliation for making their life comfortable. But the role of endoscopy is either in very early cancers, as I told you, where it is limited to the internal lining, or very advanced cancers.
Yes. I think thank you so much, Dr. Sood. I think we have learned a lot of new things. So what are the symptoms of colorectal cancer? Who is at more risk for colorectal cancer? Who needs screening? And why screening is important in colorectal cancer? Because actually, if diagnosed early, we can cure these cancers. So even if somebody is diagnosed with colorectal cancer, it's not that negative thing that it cannot be treatable. Even if it is an advanced stage, we can treat them. These patients can, after surgery, radiation, lead our normal life. And also he has stressed on how can we prevent by changing these dietary changes, by doing our lifestyle changes, we can actually prevent this cancer. Thank you so much, Dr. Sood. So if there are any questions from the audience, I think we can add to them.
Yeah. Thank you, Dr. Aman. I think you asked all the relevant questions, which must be the questions which people were wanting to ask.
So aim of basically awareness session is, as you know, as everybody knows, the March is a colorectal cancer awareness month. So we do this kind of activity to promote awareness among the general public about these colorectal cancers. So if there are no further questions, I think thank you so much, Dr. Sood, for joining us and giving us, enlightening us on this important topic. Thank you, sir.
Thank you, Aman. Thank you.